Welcome. Today we're diving into distraction osteogenesis DO, as it's often called. We'll be exploring how this technique actually generates new bone and allows for soft tissue expansion.
Hmm.
It's quite a fundamental concept in reconstructive surgery.
It really is.
The core idea is pretty straightforward, isn't it? You make a cut in the bone, an osteotomy, and then gradually pull the segments apart,
Mm-hmm.
and the body, well, it fills that gap.
Exactly. It follows a very specific sequence for the osteotomy itself, or sometimes just a corticotomy. Then there's a waiting period, the latency phase,
Right.
followed by the active distraction or activation phase, and finally, everything solidifies during consolidation.
Okay, so let's define DO a bit more formally.
Sure. It's the generation of crucially vascularized bone between those gradually separated bone ends, and this is achieved using a specialized distraction device.
Internal or external.
Correct. The whole process really banks on the body's innate healing capacity and, importantly, the ability of the surrounding soft tissues to stretch and accommodate that gradual change.
And there are critical factors for making it work.
Oh, absolutely. Vascularity is key. The tissue needs a good blood supply. Device stability is non-negotiable.
Mhm.
Then you have the latency period, getting that timing right, and the rate and rhythm of distraction, how much you pull and how often. Get those wrong, and you run into problems.
Let's talk about the bone itself. You mentioned vascularized bone.
Mhm.
How does it compare to, say, normal bone or fracture callus?
Well, the end product is essentially normal, living bone. It has both cortical and medullary components. During the process, though, we see the formation of something called the generate.
Degenerate, okay.
It's a bit like a fracture callus, you could say, but it's more structured. A key feature is that the collagen fibers within it align themselves parallel to the direction you're distracting. That's quite distinct.
And histologically, during that active pulling phase, the generate looks specific.
Very specific. You can see distinct zones if you look under a microscope. Right in the middle, the central zone, you've got lots of cells multiplying, cellular proliferation. Then, moving outwards, transitional zones where new blood vessels are forming vasculogenesis.
Right, the vascularity aspect.
Exactly. Then the paracentral zones, that's where you see those nicely aligned collagen fibers we mentioned, and osteoid, the bone precursor being laid down.
Osteoid, yeah.
After that, a mineralization front where primary calcification starts, forming little bone specules. And fulldest out, you have the mature bone zones, progressively calcifying and remodeling into proper cortical and cancellous bone.
So the bone structure develops quite systematically across the gap.
Precisely. It's a progressive maturation process.
And consolidation is when this all firms up.
That's right. Once you stop actively distracting, the consolidation phase begins. The central, less mature part of the matures, those mineralization fronts advance and merge, and you get solid bony union.
And the quality.
The final bone is, for all intents and purposes, histologically indistinguishable from the original surrounding bone. It's remarkable, really.
It is. And you mentioned the soft tissues adapting. That seems like a major plus point for this technique.
It's a huge advantage. Skin, muscle, nerves, blood vessels, they all gradually elongate along with the bone because of that slow, steady mechanical stretch.
So you avoid the issues you might get with a big single-stage movement with grafts.
Exactly. You tend to see less blood loss, lower infection risk because there's less dead space, and critically reduced relapse. The soft tissues have had time to adjust so they don't spring back as much.
Makes sense. Okay, let's walk through the actual process. Step one is the osteotomy or corticotomy.
Right. You create the bone cut. The key here is preserving the periosteum as much as possible. That's vital for the blood supply and obviously protecting nearby nerves and vessels. Minimal stripping is the goal.
Then the device goes on.
Yep. Apply the chosen distractor, fix it securely to the bone segments.
And then you wait the latency period. Why wait? Why not start pulling straight away?
Good question. That way, it allows the initial inflammatory response and shielding to kick in. You get migration of osteoprogenitor cells, those cells that will form new bone, and angiogenesis, new vessel growth into the blood clot that forms at the cut site.
Ah, so that clot is the scaffold.
It's the substrate for the generate, exactly. Without that initial biological activity, the distraction wouldn't work well.
And how long do you typically wait?
It varies. In newborns needing urgent mandibular distraction for airway problems, it might be very short, maybe 0 to 72 hours. For most other patients, it's usually around 5 to 7 days.
Okay, latency's over. Now we start activating the device. Rate and rhythm become important.
Crucial. Rate is the distance you distract per day, usually measured in millimeters.
Right.
Again, it varies. Neonates and infants might tolerate faster rates, perhaps 2 to 4 millimeters a day for the mandible. Older children and adults, typically it's around 1 millimeter per day.
And what if you get the rate wrong?
If you go too slow, the bone can heal across the gap too quickly, premature consolidation. If you go too fast, you can outstrip the body's ability to form bone, and you might end up with a fibrous union instead of solid bone.
Not ideal. And rhythm. That's how often you turn the screw, essentially.
Yes, the frequency of activation. There's evidence suggesting that breaking down the total daily distraction into smaller, more frequent increments, say, activating 2, 3, or 4 times a day instead of once, might lead to better quality bone formation. It mimics continuous distraction more closely.
So smaller, more frequent adjustments are generally better.
That's the theory, and often the practice. 2 to 4 activations per day is common.
This whole period of active distraction is the activation phase. Then comes consolidation.
Right. Once you've achieved the desired length, you stop turning the device. But it stays in place.
Why leave it in?
It acts as a rigid fixation device, like an external or internal fixator, holding the bone segment stable while that generate fully matures and mineralizes into solid bone. Union needs stability.
How long does consolidation typically take?
It's case dependent. For mandibular distraction, for example, it's often around 6 to 8 weeks.
And what do you see on X-ray at the end of consolidation?
Interestingly, often not much clear bone yet. Radiographically, the regenerate might still look quite faint or hazy when it's time to remove the device. You don't need to wait for a fully corticated bridge on the X-ray.
Good to know. Okay, where is DO typically used? What are the main indications?
It has broad applications in craniofacial surgery. Mandibular lengthening is a big one for hemifacial microsomia, general micronathia, or Pierre-Robin sequence where airway compromise is an issue. Then in the midface, Lefort-Weichsnei distraction is very useful for large advancements, say over a centimeter, especially in cleft patients with significant maxillary hypoplasia and a class 3 bite.
Okay.
For more severe syndromic conditions like Cruzon or a Pert syndrome with significant midface hypoplasia and exorbitism, you might use Lefort III or even monoblock distraction. And we also use it for posterior cranial vault expansion and some types of syndromic craniosynostosis to give the brain more room.
You mentioned devices earlier, external and internal.
Yeah.
Can you elaborate on the pros and cons?
Sure. External devices use pins through the skin connected to an outer frame. Think of the standard mandibular distractors or the RED frame, the halo device, the advantages. They're often easier to apply and remove. You can sometimes adjust the vector, the direction of pull during treatment, which is a big plus.
What the downsides?
Pin site scars are inevitable. There's a risk of pin track infection, and the devices can be cumbersome, sometimes socially stigmatizing for the patient, and potentially easier to dislodge accidentally.
And internal devices.
These are plates and screws placed directly on the bone, buried under the skin, with just a small activation arm, sometimes exiting the skin, or operated transmucosally.
Advantages there.
Minimal scarring, much less visible, less risk of dislodgement, generally better tolerated from a social aspect.
Disadvantages.
Usually they only allow distraction along a single predetermined vector. Placement can be technically more demanding, and crucially, they almost always require a second operation for removal.
Resorbable ones are on the horizon too, I hear.
Yes, that's an area of development, potentially offering the benefits of internal fixation without needing removal. Hybrid devices, too, still evolving.
Let's zoom in on mandibular distraction. What are the specific goals and surgical pearls?
Goals usually involve achieving a good bite, normalizing the jaw dimensions for aesthetics, and, importantly, airway function. Sometimes it's about reconstructing the TMJ using transport distraction, moving a segment of bone into the joint space.
Technique-wise.
Exposure can be external, like a Risdon incision below the jawline, or entirely intraoral. Pre-op imaging, like a CT scan, is vital to plan the osteotomy site precisely. A key point is often to secure the device before completing the osteotomy cut. This maintains control of the bone segments.
Stability.
Exactly. The type of osteotomy depends on the movement needed. An L-shaped or vertical cut on the ramus allows mostly horizontal advancement. A C-shape might be used to avoid the coronoid process. An oblique cut gives horizontal and some vertical change. A horizontal osteotomy allows vertical lengthening, though that's less common.
And potential pitfalls during the surgery.
You absolutely must avoid injuring developing tooth buds, especially in younger patients, and the inferior alveolar nerve. Careful planning based on imaging is paramount.
What else?
Ensuring the device is placed correctly so the distraction vector is right. If it's bilateral, ensuring the vectors are collinear, pulling in the same direction. You confirm the osteotomy is complete and the device works by activating it a turn or two before closing.
Makes sense. What about the mid-face Lefort level distractions?
Similar principles. Goals are usually achieving a class I occlusion, correcting the mid-face protrusion, especially for those larger moves over 1 centimeter, where soft tissue stretch is critical and improving overall facial harmony.
Access.
Typically a standard upper endivobuccal incision, like for a regular Lefort I. Sometimes combined with a coronal incision for higher osteotomies, like Lefort II or III, or for better access.
Osteotomy considerations.
Again, identifying the correct level, Lefort II or the III, based on the deformity and pre-op plan. And again, meticulously avoiding tooth roots and buds. After the cuts, you absolutely must confirm the segment is fully mobilized in all 3 dimensions before placing the distractor. Otherwise, it wouldn't move correctly. Then place a device, check activation, and close.
Okay. No surgery is without risks. What are the main complications or technical errors associated with DO?
Well, infection is always a possibility, either superficial or deep. Nerve injury, particularly the inferior alveolar nerve in mandibular cases, can happen.
Right.
You can get fibrous union or even non-union if things don't go well, maybe poor vascularity, instability, or too rapid distraction. Or the opposite, premature consolidation if the rate is too slow or latency too long.
You mentioned tooth buds.
Yes, tooth bud injury is a serious concern in pediatric cases. And then there's placing the device incorrectly, leading to an inappropriate vector distracting in the wrong direction. That can create a worse deformity.
And if distraction fails completely?
In some cases of non-union or significant problems, you might need to abandon the distraction plan and resort to conventional surgery with bone grafting.
Okay, so to wrap up, what are the main take-home points about distraction osteogenesis?
I'd say remember the distinct phases: osteotomy, latency, activation, consolidation. Understand that device choice and the whole plan need to be tailored to the individual case. And perhaps the biggest takeaway is the advantage of gradual soft tissue expansion that accompanies the bone lengthening. It's what allows for those large movements with often better stability and fewer complications than trying to do it all in one go.
It really is a powerful technique when used correctly. Thank you for walking us through that complex process.